Hi, everyone. I guess good afternoon for folks in the West Coast. And I don't know if hopefully there are folks from all around, but I am so happy to be here. Thank you so much, Jen, for facilitating. And I think my mentor, Dr. Apple, is also here, and just so grateful to be working among such such inspiring researchers and clinicians. And I'm super excited to talk about some of my research that I've been involved with for, I guess, a little over a decade. And I will be leaving some time at the end for questions. So as Jen said, if you could hold, if you can, your questions, or put them in the chat, and I think Jen will be able to kind of save them and organize them for the end of the talk. That would be great. So as Jen mentioned, I'm a clinical psychologist and a T32 postdoctoral fellow at UCSF, and I'm going to be talking about some research that I've conducted throughout my training, most of it prior to coming to UCSF. And the title is From Terror to Transcendence, Processes of Meaning Making in Psilocybin-Assisted Therapy for Cancer-Related Distress.
Please speak up, ma'am. Thank you.
Okay, how is that? Is that better if I talk at that volume? Can you hear me?
Yes, it sounds good.
Okay, let me know. Just shout. I tend to speak a little on the softer side, so I will speak up if I'm getting a little bit lower.
Your sentences.
I'm sorry, what did you
Your
say?
sentences. I was saying your sentences, they fade off.
Okay. Okay.
Yeah.
I will.
It sounds fine on my end. So I think
I'll do my best to project and not fade off at the end. And
sounds great.
I think there might be a way to do transcription, maybe turn on your transcription as well. I don't know if that would solve the problem, but I'll do my best. I appreciate the feedback. Okay, there we go. Has been enabled. Thank you. All right. So I'm going to talk about primarily a study and then some secondary studies that branched off of the original research that took place at NYU, and then talk about some qualitative research that I've conducted, and then some other psychological mechanisms that I've been exploring since then, and some of the research I've been conducting here. Okay, so I'm going to first talk about this sort of the statement of the problem. And cancer, I'm curious, and maybe folks can just drop in the chat or raise, I guess not raise hand, but just drop in the chat, yes, if you know someone or have had cancer, and curious how many people here have been affected by, personally, by cancer diagnosis. So unfortunately it is more common. I see some hands. Cancer is becoming one of the leading causes of death. It just continues to rise. About half or over half of Americans report that they know someone, a close family member, that have cancer. 1 in 2 men and 1 in 3 women in the US will have a cancer diagnosis by 2050. So it is, kind of a staggering number, and affects a lot of us. And, unfortunately, at least in our Western culture and society, death is, or at least the conversation around death and dying, is a really taboo subject. And from the perspective of medical science, it's, we're really, really good at keeping people alive. Our technology has improved substantially over the past several decades, but we really are not good at talking about death, preparing for death. Existential issues like existential anxiety is often overlooked in medical care. And physicians, typically are really kind of unequipped to have these conversations with their patients and don't receive the training in these psychospiritual issues. I have a quote here from one of our participants in our cancer trial. I'm going to have many more qualitative quotes further or later in the presentation, but this kind of speaks to this terror that sometimes, not everyone, a lot of people adjust to the experience of having cancer, but for many people, it feels like they're sort of earth-shattering experience. And this participant saying, you realize you're going to die. I was told I had a 50-50 chance of being alive in 5 years. As soon as you think about having limited time for living, it changes everything. So this kind of belief system that people have gets shattered, and their identity can feel really kind of disrupted by the diagnosis, and can be very hard to cope. And we unfortunately don't have many effective treatments to target this type of distress. So existential distress, the distress that is provoked by the fear of death, or the sort of struggles that people experience to adjust to the experience of having a life-threatening illness. We don't have good treatments, and it's also not really clearly defined. We don't have a diagnosis in the DSM, which is the Bible, clinical Bible that we use. And it's, we do have some pharmacological treatments, but they are not specifically, there's no evidence-based treatment for specifically this type of distress. SSRIs are often used, but they're not very effective. They're, huge sort of list of side effects, and they don't, and the psychosocial therapies that we have they don't have very large effect sizes, and there's weak evidence for them. So there's a lot of improvement we have a lot of room for improvement with identifying new treatments. So this is where psilocybin-assisted therapy comes in. I'm going to just provide a little brief overview of some of the history and background. And so there's a very long history of, or at least we think it goes back possibly millennia, at least several hundred years of use of
I'm sorry, could you please speak up? I'm sorry, I'm
yes,
not hearing
sure.
you well.
Okay, thank you. Yes, I'll speak up. So psilocybin has a really long history of sacramental use in indigenous cultures and in ritualistic practices, not just psilocybin, but other psychedelics like mescaline and mescaline and iboga. But psilocybin, which is found on most continents, has been used mostly in kind of Mexico. It has been used for sacramental purposes, and this has taught us a lot of the ways in which we incorporate psilocybin in the clinical trials today draws on the wisdom and the rituals that have been practiced with this medicine for in ritualistic indigenous contexts. So I just want to make sure that it's clear that this is not coming, that we've kind of adapted this in a Western way, but it comes from a long lineage of use. And just quickly a little bit about the pharmacology. So psilocybin belongs to a group of serotonergic tryptamines, and serotonin is actually a very similar molecule, was sort of developed or discovered at around the same time as psilocybin and LSD. And psilocybin is, when it's metabolized in the body, it is the phosphate group is cleaved off. So what really is the active molecule that's metabolized is psilocin. And the 5-HT, so this is serotonin subreceptor called the 2A receptor, is the kind of magic, or it's like the key that unlocks the pharmacological effects, also important in the metabolism of other serotonergic psychedelics. So this receptor is what we believe is kind of what activates the subjective psychological effects. And psilocybin lasts about 4 to 6 hours, and it has a half-life of about 2.5 hours. So typically a session lasts, it can last almost a full day when we have sort of our start and end. Just a quick note about the harm potential. So psilocybin, I see at the very far of this graph. This is mapping or graphing the relative harms of drug abuse. This is in a sample from the UK. And you can see all the way on the left is alcohol. So this is from a 0 to 100 scale. Alcohol is ranked to be the highest in terms of relative harm potential to society. Psilocybin, LSD is also on that far end, has been found to be one of on the lowest. And there's really no evidence of traditional reinforcing, so physiological dependence. There is a risk of psychological dependence, but when used in a sort of supervised context, that's very, very low. So just physiologically, we know that this is a very safe medicine. And the historical use, there's a rich historical, at least in the Western context, of use of psilocybin in the 50s, 60s, early 70s, before Prohibition era, early 1970s, prohibited the use of psychedelics, classic psychedelics. So in the 1960s, LSD was mostly used. It's very kind of has a similar profile to psilocybin, mostly used to treat alcoholism and existential distress associated with a life-threatening illness. And so it was, there were about 50,000 participants and 1,000 or so clinical papers. So there's a large preliminary evidence base. Studies weren't as rigorous as the ones that we have today, but there was, it really paved the way for some of the more recent research, and a lot of the sort of paradigms that we use are also drawn from these studies. And so, I just sort of getting to set the context for how psychedelics might be useful in addressing existential distress. And I'm going to quickly talk about these seminal kind of landmark studies that kind of paved the way more recently. So in 1962, there was a researcher at Harvard named Walter Pahnke, who conducted a study called the Good Friday experiment on Good Friday in 1962. He gave psilocybin there were 20 divinity students, Harvard divinity students. Half of them received psilocybin, half of them received a placebo, and they attended this Good Friday service. And the ones who received psilocybin reported this, basically what they reported, like a genuine mystical religious type experience. It was followed up by Roland Griffiths at Johns Hopkins, very similar design, same placebo as niacin and psilocybin, and found that compared to the placebo, there was a between group significant difference, and the participants who had psilocybin are rating a top 5 spiritually most significant experiences of their lives, and similar to this Good Friday experiment, rating these psilocybin experiences as like genuinely spiritual. So something about this type of experience being really powerful and stimulating, it's an altered state that is described in very spiritual terms. All right, so I'm going to spend a little bit of time on here. It's very important when we talk about psilocybin in particular, to talk about ego dissolution. Default mode network is a brain region that's becoming really popular, not just within this research space, but other psychiatric research, and psychological flexibility from a psychological sort of mechanistic perspective. So with psilocybin, it is extremely common for the person taking the medicine to experience this kind of softening of their sense of self and the boundaries between themselves and other. And we think that's mediated by this receptor, the 2A serotonin receptor. And what's also happening is this part of the brain called the default mode network, which is involved in self-related processing as well as mind wandering. It's hyperactive in disorders that are really characterized by kind of psychological rigidity, so depression and substance use, and as well potentially with anxiety associated with existential distress. We see these kind of rigidified narratives about self that get really kind of embedded. And so what can happen is we get kind of tightly kind of fused with these narratives about ourselves. And what can happen with psilocybin in particular is if we can kind of dissolve the boundaries of these sense of self, and we temporarily, with therapeutic support, the context is really important. I will talk more about that in a little bit. That might create sort of a window in which new learning can take place. And kind of, we think that the default mode network is activity that part of the brain is being reduced, and then that's allowing different sort of flows of information. So we do think that actually liberates this kind of emotion limbic system processes, and creating more interconnectivity between brain networks that often are not communicating. So if you see in these pictures, just like the ones on the bottom, actually let's start with the one on the right, with the placebo and psilocybin. So this is a kind of complex homological scaffold, but basically what we're, the takeaway is that there's increased communication between cortical regions of the brain and the executive functions, and less constrained and more kind of communication between modes of the brain that often are not speaking to each other. And on the left, you see that actually the default mode network is being diminished, and there is cross communication between the medial prefrontal cortex and the posterior cingulate cortex. So in deep states of meditation, we're seeing actually very similar brain states in which there's increased activity between parts of the brain that are not often communicating or otherwise communicating, and also can be compared to like defragmenting a computer, updating a hard drive. And I don't have the pictures here, but there's also been some interesting research or neuroscientific evidence to show that there is some interesting amygdala activity that takes place. So it seems like acutely there might be increased amygdala activity, which is a region of the brain that's associated with fear processing. And it's interesting to think that there might be acute activity, increased activity in that part of the brain, but then a week later, we're seeing that, so we call it like a post-acutely, that there is reduction in the fear processing, but there seems to be something different than the mechanistic action of traditional antidepressants that seem to decrease amygdala activity. And so we're getting some clues here about potentially why psilocybin's therapeutic. And we think that it's possibly that we're actually accessing emotional parts of the brain, and that the sort of therapeutic action may have to do with that we're confronting emotions that maybe were avoided. They might be difficult, painful emotions, but that might be what's needed to really be therapeutic. Okay, so I know that was a little complex, but I'm going to I'm going to present some qualitative research, so hopefully that will kind of help to integrate some of that information. So I'm going to talk now about the design of the 2016 study that I was involved with at NYU with Stephen Ross, who was the principal investigator. And then there were a couple of follow-up studies that I will present data from. Okay, so this study, we actually collaborated with our colleagues at Johns Hopkins University. We co-published this study in, 2016. And this was a phase 2 study, randomized controlled trial, had a crossover design, which means that participants in the study all received the active, so the psilocybin medication, and they received a placebo, and then they each basically crossed over to the other condition at 7 weeks. And then I have a diagram on the next slide that will show kind of pictorially the flow of the timeline of the study. And we had 29 participants. Hopkins, they had, I think, 51, and we co-published this together. So the sort of sample size that we had together was about 80. And it took a long time to conduct this study. It took about almost 10 years from start to finish. So here is the timeline. We had on the top, you can see that there was a lot of psychotherapy. We had 3 sessions of about 2 hours each of psychotherapy in the beginning. Then they each were randomized to a dose condition in which they received psilocybin first, niacin, which is like a B vitamin, that's a placebo second, or they had the niacin first, the psilocybin second, and that was separated by 7 weeks with more therapy in between that first medication session and the second. Then there was a lot of integration, so supportive therapy to help process the experience or the medication sessions. And then there were several follow-ups. I'm going to be talking about those follow-up studies that we conducted. And let's see if there's anything else I want to say about here. You can see on the bottom the measures that we use. Our primary measures were anxiety and depression. And we had a bunch of secondary measures measuring things like the like quality of life, existential distress, spirituality, and if there's anything else I want to say about here. No, I will. I imagine there'll be some questions about the design that I can answer at the end. I'll come back to the slide if needed. A lot of text here, but I want to explain. I know there are some psychotherapists in the audience, so I want to describe the therapy platform that we used. And it's really important because we're not just giving people psilocybin. It's not a drug study really per se. We're not just studying, or not a pharmacological, like a traditional study where you're just giving the, like an SSRI, and having them kind of go home. They are, receiving it in a very structured therapeutic context. So the model that we used for therapy was sort of integrated, meaning-focused psychotherapy, logotherapy, targeting loss of meaning, and capitalizing on this, as I think we talked about in the Good Friday slide. There's something about psilocybin that seems to trigger these highly salient, spiritual, highly meaningful experiences. So we think the synergy of those things is what might be therapeutically effective. And so we wanted to leverage that. And then there was a lot of preparatory work where we took we got a lot of information about participants' cancer stories, their life narratives, and prepared them for the 2 medication sessions that they had. And this was blinded, randomized, so no one, not even the study team, knew which condition they were in. So we did not know on which session they received the psilocybin. Although, it is, psilocybin does have kind of it wasn't, you'd be surprised actually that some people had what we think are what they rated as mystical type experiences on their placebo dose, but it's hard to blind. It's really hard to blind in these studies, or to like kind of not to really, to blind the conditions. But we did our best with the design. And the medication sessions, participants were encouraged to accept whatever emerges. Trust, let go, be open was the mantra that we encouraged them to kind of hold, and to surrender as much as possible to whatever arises, even unpleasant emotions. And then integration, supporting them in reflecting, finding meaning, developing practices to support them in kind of moving forward in their lives with the insights that they might have experienced during their medication sessions. So here is a picture. This is not a real participant, but this is what the room looked like. And they would come in for about an 8-hour session and would lie on the couch that was prepared in kind of a bed-like fashion. They would wear eye shades directed to go inward, listening to music, and we would assess their blood pressure throughout. It's a common artifact of the experience. People do tend to get increased blood pressure, so we were monitoring that, and definitely different than Indigenous sort of group focus or group context. This is much more westernized version of the or paradigm, and very much influenced by the work that was done at Maryland Psychiatric Institute, where Walter Pahnke had worked, and Bill Richards, who's at Johns Hopkins right now, and is a big kind of part of the research today. Where a lot of this format is really influenced by the work that took place then in the early 70s. So what we found, let's keep going time. Yeah, what we found was that, you can see here, these are the 2 dose conditions. So this is in psilocybin first group is in purple. I realize, oh yeah, here's a yeah, psilocybin first group is in purple. You can see that the this is up to the crossover. So this is a true between group comparison. Essentially what we're seeing here is that there is some improvement in the placebo group, but much more pronounced in the psilocybin group. So obviously there's a treatment effect of just having the therapy and the set and setting, which refers to the psychological preparation and the mindset of the participant and the environment that we create around it. But it's much more, much stronger in that psilocybin group and large effect sizes. So over 1, and much larger than what we see with antidepressants. And then we also found that the mystical type experience, so there's a validated scale that came out of a group at Johns Hopkins that measures the quality of the mystical type, or the strength of the mystical type experience. And we found that this mediated, so essentially what that means is that it transmitted the effects or explains why there were reductions in anxiety, depression. However, this only explains that it's up to the 6-week point. We've had follow-up we had several follow-ups. So we ended up in the first study had follow-up up until like 6.5 month follow-up. And then I conducted a long-term follow-up, where it was up to about 4.5 years. So I'll talk about that in a second. But I'm going to just show here that the one of our secondary papers that we published just last year, we went back, looked at the data, looked at suicidal ideation and loss of meaning, and found that although it was a very small, we were sort of underpowered, and we weren't, it wasn't our primary indication. So not everyone came in with suicidal ideation. But so the group that we analyzed, or the subgroup that we analyzed, not everyone was had suicidal ideation, so it was a smaller sample size. But we did find this actually interesting treatment effect, and loss of meaning was also decreased. And then we also found an association between changes in suicidal ideation and changes in depression scores. So there's, this might be pointing to why or how psilocybin can be effective, and can, there are actually high rates of suicidal ideation among this population that are kind of associated with this demoralization and existential distress. So that is an interesting finding. And then a couple years ago, followed up with the participants. We had a much smaller sample size, by half or so. We had to, because a lot of the participants had passed away, but we administered assessments about 2 different time points, about 3 years and 4.5 years later. And so we don't have any between group comparison at this point, because they all at this point have received both conditions. and or both medications. But it's interesting that at this, at these very long-term follow-ups, the participants who were included in this analysis are still reporting these very pronounced reductions all these years later. And we did actually look to see if the stage of cancer was maybe was predictive of this, and we found no correlation. So it does seem like it's not a function of whether people are, granted we didn't, there were people that had passed away who weren't included, but it seems to be that people are continuing to experience the benefits, and it's not related to what stage, whether they're at an earlier stage of their diagnosis or in remission. And the response and remission rate at the second follow-up, at this 4.5-year follow-up, was very high. So response rate is defined as 50% or greater reduction in, so in this case, depression, and this long-term follow-up. So we're seeing very high percentage of participants, so like 60 to 80% are reporting still this clinical response, and remission is the 50% response plus beneath the score of 7 on the HADS depression scale or on the BDI. So pretty interesting that we're seeing that. And then I'm really like this finding as well, that there's this relationship between the time elapsed and the reductions in hopelessness and depression, which suggests that people are continuing to get better over time, that like more time passes, the more they are reporting reduced depression and hopelessness. And persisting effects all these years, 4.5 years later, continue to report that psilocybin experience that they had was in the top 5, or like the single most personally meaningful or spiritually significant experience of their lives. But interestingly, that relationship, that mediation and relationship with mystical type experience did not, it could potentially could be a power reason, but it did not mediate the long-term effects. So that means, or was not correlated with the long-term effects. So we don't know. It's possible that we just didn't have enough of a strong enough sample size, or we didn't have enough power with a high enough sample size to detect the effects. Or it could be that at this long-term follow-up, there are other things going on, not just the spiritual experience, but maybe something in the long-term, new sort of coping strategies that might sort of help us understand why, or new coping strategies that they're developing that we just maybe still don't know yet. And this brings me to some qualitative research and some other research I'm doing to help sort of address this question. We are doing time. Okay, I think we're getting close. So I am really excited about qualitative research. I think I saw one of my colleagues on the call, Eve Ekman, who is one of my, a dear friend and colleague who is a qualitative researcher as well. And we've conducted some qualitative research together on, so on a different population, we looked at long-term AIDS survivors, but also the same clinical indication, existential distress. And what I'm really intrigued by is that we're finding that even though it's a population that, or at least the cancer population, is not coming in with specifically PTSD or diagnosable PTSD, we are seeing that folks are reporting, qualitatively, that they are able to reinterpret painful or traumatic past events acutely during the psilocybin experience. That helps them kind of recontextualize them and sort of find meaning in these experiences that were previously really negatively impacting their sort of identities, or were not able to kind of integrate them in a way that was helpful. They kind of were stuck emotionally. And so I'm just going to share, I might not read all the quotes, but I will read the first one. So there was this participant who had this who had this image during her psilocybin session of cancer at the dinner table. So I was supposed to be at the dinner table. The feeling I had was cancer is a part of everything. It isn't this bad separate thing. It's something that's part of everything. And this other quote about trauma, also someone who was in our cancer study, not being a part of my defining narrative, but at the same time, there's this way of keeping it as part of me without it defining me completely. And then there's these relational insights. A lot of people have these, these kind of new understandings of their relationships and resentments that they've held towards family members or harbored towards family members or loved ones they're able to let go of and forgive. So this person, I felt like my family was doing their best. They tried their hardest, or that people tried as hard as they could. And certain things from the past that was okay. Another participant letting go of anger and resentment. And I thought I had already done that, but I really hadn't. And I kind of saw them more as these flawed human beings who did the best they could. And then the spiritual level, seeing myself as part of something bigger, I felt myself connected into what had been the collective mind, realizing it's like, oh, this exists. We're all just facets of this. I know that rationally, but it's time to feel that in a very real sense. So I like to kind of highlight that these personal, relational, more kind of cosmic, spiritual dimensions, because these are happening on kind of multi-dimensional way, a lot of these insights. And it's this kind of reinterpretation of both past and painful current sort of current parts of their their life that seems to be happening, or that psilocybin seems to be catalyzing. And I'm going to talk a little bit about what I think is psychologically how psilocybin might be mechanistically sort of in producing or facilitating these processes of recontextualizing past events. And so I talked a little bit earlier about psychological flexibility and the brain becoming more interconnected. And so there's more and more research that's coming out. So my colleague, Alan Davis, found that increased psychological flexibility occurring after a psilocybin, this was, I think, multiple psychedelics or different types of psychedelics, was mediating these decreases in depression, anxiety. I conducted a study actually with ayahuasca that found similarly psychological flexibility increases mediating the increases in positive mood, and reappraisal seems to be acutely during the psilocybin session, psychological reappraisal, to talk about in just a second, mediating the effects. And so reappraisal, I am working on validating a reappraisal scale that measures how much people are, during their sessions, kind of revisiting past traumas, finding new meaning in them. As you can see here, these items such as I was able to see new positive meaning in a past trauma, and felt forgiveness, forced to confront negative perceptions I've had about myself. So what I think is happening, or my hunch, is that during a psilocybin session, it can provide this really powerful opportunity for people to kind of broaden their awareness, develop new ways of kind of understanding how these different parts of their lives fit into their larger life narrative, and develop kind of more growth and meaning. It's kind of in this diagram. This is a diagram showing reappraisal from a mindfulness perspective, how the container, the sort of broad and attentional field, is able to encompass both the negative and the positive, rather than being kind of focused just on the negative. All right, and then this is my proposed model. It's not been validated or tested, but hopefully I will at some point. But very similar to how I think mindfulness mechanistically helps develop, or helps people kind of develop better emotion regulation, and increased sort of mood or improved mood is this ability that psilocybin has to dissolve boundaries between self and other, broaden one's awareness, access emotions that are previously avoided, process those emotions, and then in the long term seems to help people develop just greater ability to regulate their emotions and to develop psychological flexibility and relate to these events in their life or cancer in this case of these studies that allows them to kind of have a more flexible understanding, flexible narrative of their lives. And just, I think we're almost through. I just have a couple more slides here about emotional uncoupling. So I think what might be happening here with the psychological flexibility and reappraisal is that, is that they're able to kind of defuse, uncouple from cancer, which was previously viewed as this kind of very like life-shattering experience. And for some of the participants, they're actually processing emotions that had nothing to do with cancer. So like this person who said cancer was nowhere in evidence. If anything, it was part of that same smoky, shadowy chaos of anger and fear. And I actually realized I've repeated the quote here, which I shared earlier, but it's this kind of ability to think of cancer as something that can be managed, not avoided, and actually it's allowing them to, it's like an opportunity to approach emotions that maybe had been repressed for a long time. Maybe there's some relationship between emotional styles of coping and just like in the way that they kind of are coping with their cancer. So limitations and future directions. So there's so much I could put on the slide, but I just want to highlight that we are, in the renaissance of psychedelic research, and it's exciting times. We are moving towards phase 3 studies, which will allow us to, build a larger evidence base for then possibly rescheduling of psilocybin out of its Schedule 1 category, which has made it very hard to conduct research. So with the cancer studies, we will be moving into the phase 3. We have protocols developed. We're just looking for funding. Hopefully NIH will start funding this research. More research into psychological mechanisms, really understanding mechanisms that govern the process of symptom reduction is really important. Developing targeted interventions to optimize outcomes. The research studies in particular have been abysmal when it comes to diversity, equity, and inclusion. About 80-something% white identified individuals. So we need to increase our efforts to include more diverse participants and collaborate with communities, and community-based participatory research I think is really important here as well. And there's a lot of mistrust in the BIPOC community around participating in research. So it's a complex issue, but we need to do better there. And supporting reciprocity efforts, the wisdom that we've drawn from Indigenous communities who are not benefiting at this point or profiting from it's like a kind of multi-billion-dollar industry we have with psychedelics. So important to really include them in this in this process, and hopefully create systems in which they can financially also benefit. And just leave you with a couple quotes to speak to the existential piece here. And then I'll take questions. So Roshi Joan Halifax, actually, she was one of the original people she lives in New Mexico, and she is in the meditation community and writes, does retreats on death and dying. And so she writes here, life-threatening illness calls us to a place, metaphorically a desert or a mountain peak, whereas we sit, the hard wind of reality strips all the trappings of life. And of course, Viktor Frankl, so much of this meaning-focused therapy comes from his work and surviving the Holocaust. And speaking to how we can have this, we can choose our attitude in any given circumstances to choose one's way, no matter what, we're facing. And that is, and here's our team. Not everyone, and the team has grown since I've left NYU, but here's some of the study team, and I'll take some questions with the 11 minutes we have left.
Great, thank you. That was an amazing presentation. I think this is our best attended research seminar, so I think that just speaks to how interested and excited everyone is about this research. I have a number of questions, starting with a question from Shonda Williams. Thank you for your presentation. The question is regarding equity, diversity, and access. I think you touched on this a bit, but maybe an opportunity to elaborate. The research is showing that psychedelic-assisted psychotherapy has the potential to heal or alleviate many types of psychological and emotional distress. Would you describe the demographics of the participants in your research by age, race, sex, and so on? And could you describe some of the efforts to advance health equity and access for people of color in this research?
Yes, thank you, Shonda. So important. And so to answer your question about the demographics, there's some important research coming out of Dr. Monica Williams' lab. She's now in Ottawa. I think she's in Ottawa now. She's in Canada. I'm pretty sure it's Ottawa, University of Ottawa. She's been leading the efforts in this area. There was a review paper that she published a couple years ago that reviewed all the studies, I think not just with psilocybin, but with, I think, MDMA and I believe, I think all the psychedelic studies have been published, and she found that in the aggregate, it was about 80, something like 80, potentially 85 to 90% white identified individuals, and then socioeconomic like income brackets, also like middle class to upper middle class. So it's a real problem. I think we need better recruitment efforts. That's been a kind of passive recruitment strategy that most of the studies have used. And I mean, to be honest, psychedelics are kind of it is a very white, the communities have been kind of white, predominantly white, just, the sort of cultural it just has evolved in that way. However, there's a lot of really interesting research and efforts by organizations like MAPS, the Multidisciplinary Association for Psychedelic Studies, prioritizing training of BIPOC individuals to develop studies that focus specifically on racialized trauma, so racial trauma, and I think, as I mentioned, I think really developing community-based participatory sort of strategies and partnerships is really important to advance these equity issues.
Okay, I have an anonymous question here. I'm just going in order. So for your the crossover trial and the long-term follow-up, I wonder if you have any information about patients with similar diagnoses who did not have any treatment for the long-term outcomes. And I was also curious, separate from this person's question, those effect sizes look so large, and I wonder if additionally, like what are the effect sizes for more standard pharmacological treatments long-term?
I'll answer the second one first. So it's somewhere between like 0.3 and 0.5. It's somewhere like that, 0.3, 0.5 for, I think, antidepressants, and then for like CBT and so that's like there's like the pharmacological effect size, and there's then the psychosocial treatments. I don't remember offhand. There's a review paper by Jason Loma who actually compares the effect sizes, and it's something like psilocybin or the psychedelics are like twice as large at least. But I think for like the sort of behavioral psychosocial therapies, there's maybe a larger range, but they're in the low to moderate, maybe high moderate effect sizes with up to maybe like 0.7 or so, 0.6, 0.7. So yeah, our effect sizes, I mean, granted, there is this kind of phenomenon where you, at the beginning, when we start to do the novel research into novel areas of investigation, you do see higher treatment effects, and then it could sort of diminish as we continue to do larger studies where populations of more generalizable, complex populations. These are highly, these participants have, not very complicated, psychiatric pictures, but yeah, it's pretty pronounced, the difference, and it speaks to how powerful, and I think what these this sort of existential spiritual kind of piece here is that these are very personally meaningful. There's something like very profound about these experiences that seems to sort of augment the therapeutic process. Sorry, Jen, there was a first part of your question that I'm
well, and then also comparing to people without any treatment.
Without any treatment. So are you talking about, so if we had like a third condition where
Right.
there was like a wait list or something? So I haven't been involved in wait list control studies, but Johns Hopkins, they have done, I think, a depression study that was published not too long ago. It was actually published in JAMA Psychiatry. They compared, there was a group with psilocybin treated to a wait list where they just had no treatment. It was very high between group effects, but I don't remember the effect size, and I don't know what it would be if there was like a third arm here, if that has been done before.
Okay.
Yeah.
Okay, and then I think there are a couple questions where probably underlying it is like, how do we get this to patients who we think might benefit from it? So first, do you have any open trials that you're recruiting right now? And then maybe related, do you have recommendations for clinics or agencies who are providing these services?
So yes, so let's see. So it's a whole proliferation now of research. And if you go to clinicaltrials.gov and you search for, you can do the filtering of psilocybin and active recruiting studies. That's what I recommend. I'll put that in the chat. That's the best way to find studies. But offhand, there is actually a study, I don't know if it's still running, there is a group therapy. That's a very interesting area at UCSF. I was involved with Brian Anderson, this trial that involved long-term AIDS survivors with a group therapy paradigm. And I think that also is a really, really beautiful application or context in which to use these medicines, because there is such a social component, and connectedness is another big phenomenological sort of finding that we're seeing. But I'm pretty sure that there's maybe still recruiting for this cancer distress group therapy study. And then there is a depression study, USONA Institute. It's multi-site studies. There's actually one at UCSF that's running, I think, still currently. And then there's there's a lot of research with psilocybin for other clinical indications, like addiction, and an alcohol study will be starting. Psilocybin for alcohol use disorder will also be starting at UCSF probably pretty soon. That will be, the site PI will be Jennifer Mitchell. And yeah, there's so much. So basically the answer is there's a lot. And the different eligibility criteria. So we just have to go to the study page, start with clinicaltrials.gov. That's probably the best place to go. Oh, Andrew said it just closed last week. That's too bad. Okay, so no longer the UCSF USONA depression study. Parkinson's studies, Andrew maybe can answer. There is a Parkinson's related depression study, I think, maybe at UCSF. Andrew, or do you know about that? Brenda asked about Parkinson's. Currently recruiting for Parkinson's depression, yes. So you can go to the, I don't know, maybe psychedelics.ucsf.edu, look at the studies there. Yes.
Great. Gosh, there are so many more interesting questions in the chat, but we're about out of time. So I just wanted to take a moment. Maybe if you want to stop sharing your screen and if people feel comfortable putting their video on, just so we can say thank you. Like you said, this is really like the field is at its renaissance, and I feel like you are at the forefront of this. We're so lucky to have you at UCSF and so grateful that you came here to speak today. Thank you.
Thank you.